Good morning. Welcome to Arcadia Bite Size Talk. I'm Rich Parker, Chief Medical Officer for Arcadia, and it is truly my pleasure to do this presentation with Robin Travers and Dr. Doug Carr, two friends of mine. They are a customer called Umpqua, Douglas County, Oregon, and I'm going to let them introduce themselves. Robin, you go first.
Yeah, hi, I'm Robin Traver. I am the Vice President of Clinical Operations for Umpqua Health. So I oversee the part of our business that is responsible for care coordination, both on our medical side and our behavioral health side, our pharmacy teams, our claims and administration, and customer service. So I'll pass.
Thank you, Robin. Dr. Carr?
Oh, I have to use this. Okay. I'm Douglas Carr. I'm Chief Medical Officer at Umpqua Health, and I'm a dyad leader with Robin over the clinical operations.
Great. Well, thank you both for coming. Just by way of introduction of today's talk, in healthcare with data and analytics, our goal is to do useful things. And sometimes we struggle with that in healthcare. But today I am delighted to present to you a useful thing that our friends at Umpqua did, and I'm not going to steal their thunder. I'm going to let them present it. So, Robin, I will let you take it away with the slides.
Yeah, so we are going to be talking about how we use Arcadia's system for a project we're calling the Clean Air Project. And it's really looking at how we're using their system to target, social determinants of health issues, risk, respiratory risk, and then also using their product for workflow automation and outreach to our members. So just for some background about our organization, I'll pass it to Dr. Carr to give a quick overview.
So in Oregon, we have a unique approach toward Medicaid. The state gives the management of Medicaid lives over to smaller organizations called community care organizations, or CCOs. So for Umpqua Health, we are the unique example of a CCO. That is, we have the local Douglas County IPA and our local sole provider community hospital that have come together to create the CCO. And we manage a third of the entire county population, about 35,000 members. It's a rural county, and it extends, it's really the heart of the lumber industry where Roseburg Forest Products first began. And it extends all the way from Crater Lake to the ocean. And so the unique architecture, geography of the county has an impact on how we deliver care.
And so this is just really a high-level look at our care coordination program and our strategy that we use at Umpqua Health. So as Dr. Carr has mentioned, we are a payer, but we also coordinate care. So we have a fantastic team for care coordination. We kind of have a matrix organization where we pull expertise from other areas as well that do care coordination interventions. But we have, on our care coordination team, we have nurses, we have social workers, mental health professionals, we actually have a pharmacist as well that helps do kind of the medication side of that, medication therapy management. And we also have community health workers and peer navigators that help kind of navigate the health system. When we look at the things that we do, a lot of what we do is driven by our health risk assessment in Arcadia's platform. So that health risk assessment is essentially a list of questions, and it has automation factors in it. So when a member, for example, answers a question if they are experiencing food insecurity, so if they're having trouble, or if they're worried about losing, not having enough food within the next month, those types of things, it will trigger it for that person to enroll into a program with our community health workers, for example. So that risk assessment is a really great tool that we use that really drives all the work that we do. Through that, we can identify members' physical and behavioral health care needs, as well as those social determinants of health, those unmet needs like housing, all of those items. And then it'll, like I said, it will trigger enrollment into our case management programs. So some of those include like chronic disease state management, medication therapy management, behavioral health. We have, SDoH program as well. And through those programs, they'll work with our care coordinators and complete a care plan. And so that really is driven through Arcadia's platform as well. We have individualized goals and interventions for those items so that as someone is going through the health risk assessment, going through some of our other assessments, they are triggered to add a goal and intervention specific to that problem. So that really helps us track the completion of those goals and really show outcomes of the work we do as well. We also can coordinate referrals with internal and external partners, connecting our members with community resources as needed, and that's all tracked in Arcadia's system. Yeah. One of the things that we do at Umpqua Health is, we really try to have a health equity lens in everything we do. We look at social determinants of health. We try to make sure that sometimes those underlying factors that really need addressing first, we focus on those. This is a survey from some of our members and community partners to really prioritize the top needs in Douglas County. So as you can see, housing, behavioral, and mental health are really the top two categories that our members need support within our community. Healthy behaviors as well. So that's number 3. That's pretty high for us. And one of the driving factors for that is really the smoking rate. So we have the second highest rate of smoking in the state of Oregon. We have about 40%, or actually, I'm sorry, a third of our members, 32%, smoke. So that is, a big risk factor for our community and something we've been actively working on. Some of the other things on here might be a little bit higher than other communities, like transportation, social isolation, and supports as well. And that's really a function of being a rural county, some access issues there that we've really tried to address.
Robin, if I could just make an editorial comment, I think this is a really fantastic graphic presentation using data to show the real needs in your county. And I can't say I've seen it done better than this anywhere else.
Yeah, thank you.
Yeah.
So it is definitely very important to us. So, but kind of drilling down to this specific project, one of the things, I mentioned we have a lot of respiratory risk in our county already just with the smoking rate. But additionally in Oregon, this is a nice graphic that shows the wildfire impact over the course of several decades. So I've actually, just a little background for myself, I've lived in Oregon my whole life. I recently just moved across the border in Washington, but when I was a kid, I never remember seeing any wildfire smoke in the summer. I would say the last 4 or 5 years, pretty regularly, every summer, we have very visible wildfire smoke in a lot of areas of the state. A lot of times, we can't go outside for long periods of time due to that wildfire smoke. So, and a lot of times these, mega fires that we'll get will burn for several months, and we'll start seeing increase in utilization of inhaler use, that type of thing. So it really increases that respiratory risk the longer that those fires burn and the longer that air quality is an issue. So in 2022, the Oregon Health Authority, there was legislation that allowed them to purchase air purifiers, air filtration devices, and distribute them to the CCOs, so to distribute to members at high risk. So we kind of had this new project. It was a pretty quick timeline where we had to identify members that would most benefit from these units, notify them that they're eligible for it, and then distribute them to the members. So the workflow that we used Arcadia's risk report, respiratory risk report. So that allowed us to identify members that had the higher risk of respiratory complications, whether they had, asthma, COPD, or cardiac, conditions as well. But that really identified, I think we had a list of about 850 members that we outreached to. Most of those we weren't able to get a hold of, but about 40% of them accepted the offer, and they either came and picked up the device from us, or we delivered them to them using our community health workers. One of the neat things with Arcadia software that we were able to identify the members using that respiratory risk report, add them to a patient registry, and then use the outreach function to send texts to these members to notify them. So it was kind of a seamless, quick way of facilitating that workflow. It was really effective. And then I put some of the other outcomes here. So one of the things that we do is when we have an opportunity like this to connect with members, especially if we're giving them something, to try to engage them in some of our other programs. So we had 148 of those members that either did not have a health risk assessment or did not have one on file that was updated. And so we had them complete those risk assessments, and that drove 42 new program enrollments based on those risk assessments. 97 care plans were added or updated in Arcadia system as a result of that. And then ultimately we had 287 goals and 386 interventions completed.
Dr. Carr, would you like to comment?
Yes, I also want to emphasize that the respiratory risk profile allowed us to identify those at risk who are really going to utilize, get the best benefit out of the air filtration. But we also could overlay factors around race, ethnicity, and even SOGI data, so that we could identify those historically marginalized groups and double down, triple down the kind of impact or outreach that we would have to make sure that the outcomes, which is the health equity piece, were approximately the same as in the dominant culture.
Yeah, that's a very good point. We definitely have those factors in our interventions so that we can kind of cast a wider net and ensure that we're encompassing all of those that are historically there's disparity based on the data that we have. But ultimately, this was really, I think, a great way of using the data analytics to then target members, to drive the intervention and workflow automation, and then also to use that as an opportunity to engage with members and see what else we could help them with. So that's kind of the whole 360 picture of what we did. Yeah. Any questions for us? Yeah.
Robin, can you characterize the question so we can hear it? Thank you.
Yeah, absolutely. That was a great question. The question was really around, how do we address these social determinants of health issues? Is that correct? How are we targeting them? So this really, all of these SDoH factors essentially are items or questions on our health risk assessment that we do. So that's a really great question. So for example, if someone has a housing issue, we will connect them with we have an asset map that we've worked on that shows, all of our assets within the community for transitional housing, really depending on the member's factors. So if it's someone that is experiencing homelessness, for example, we would use more of a transitional housing approach versus someone that's having trouble making their rent. We can use our flexible services. So we have this pool of money that we can use for addressing some of these issues. So a lot of it is connecting with community resources. We do definitely provide education to our members as well, how to navigate those resources, but also, health education for certain items such as, the healthy behaviors and cigarette smoking cessation. Does that answer your question? Okay. That's a great question. So, yeah, the question is when we identify, there might be 18 factors or 18 needs that the member has, how do we prioritize addressing those? That's a really good question. We tend to address, so our care coordinators are really skilled at doing this, at triaging. They look at things like, so if someone is in imminent need of housing, for example, if they're getting discharged from the hospital and they don't have anywhere to go over the weekend, that would be, the first thing that they would address. So housing, the basic needs, I think, are usually the most urgent to take care of. So making sure people are, housed, fed, all of those items. And then you can kind of start addressing some of the other, sometimes more of the chronic or the healthcare kind of conditions. And a lot of times we have a daily huddle, and a lot of times there's a lot of talking among our staff and trying to, troubleshoot and figure out the best approach, because there isn't a lot of solutions sometimes, but they're a wonderful team, and I'm always impressed how they can kind of navigate those things.
Oregon Medicaid specifically has part of 4.5% of our premium dollar is set aside for health-related services. So we either on an individual basis for individual expenditures or more of a community-wide initiatives. And so we will identify and use those funds to do the to provide instant housing, motels for intervention post hospitalization or in someone in need, and then we try to figure out how to wrap around and change the temporary housing into more permanent housing.
Yeah, the question was, how did we identify, she wanted to hear a little bit more about how we identified the patients that would benefit from the inhaler, or I'm sorry, the air purifier devices. There is a respiratory risk report in Arcadia system, and it looks at things like diagnosis, I think is a big one, asthma, COPD, some of the cardiac conditions as well. And I believe that it looks at inpatient and ED utilization as well. I'm not sure if we know what else that report, but essentially it creates like an algorithm, and there's a risk score that's reported on that report. It kind of just a little bit of background on that. The state of Oregon actually gave us a list to use. And as we kind of went through that list, we didn't really see a lot of correlation from who we would think would be the sickest members or the highest risk members. But then using the risk report, we went through, started from the top down, and we really saw like, oh yes, this person's been in and out of the emergency room quite a bit for COPD exacerbations. So we definitely, I think we saw a stronger correlation with that report.
Indeed. So here it is, the state has claims data, same as our claims data, but they don't have a system. They don't have an analytic black box with a lot of intelligence behind it to really extract the information that's actionable. And so that's the difference between data and knowledge.
So the question was, if we had, what would we advise for someone trying to develop a SDoH strategy for employers? And when you say employers, are you a payer on the payer side of things or on the care delivery side? A bit of both. Yeah. Yeah. Yeah, so for employee health, yeah, I think that, and there might be a little bit different makeup in that cohort compared to like the Medicaid cohort, those that are currently unemployed. But I think just doing an assessment, I think a lot of it might be around behavioral mental health, making sure that employees feel supported there and they have resources that they can use. If there is any issues, with meeting basic needs like housing, food instability, I think just a general assessment, I think would be a nice thing to do for employees. And then one of the things that seems so simple, but it really was helpful, is to develop like an asset map and say, these are all of your resources in these areas. So you can look at someone, you can see their different factors, and you can connect them to the best resource. That is kind of a lot of what we do.
I just want to add to Robin's answer, which is if you take a big step back, even internationally, other countries spend a lot higher percentage of their GDP on social services. And in the United States, we spend a higher percentage of our GDP on healthcare. And therefore, a lot of the needs in the community look to healthcare to solve, this gentleman was asking, to solve all these problems, which obviously we cannot. However, we can connect with so many of these other services to do outreach. And I think that's part of what Umpqua has shown us here today, that it's not just healthcare, but you're connecting with resources to work on housing. And housing, as it turns out, housing insecurity creates so many problems for patients, because if they're housing insecure, they can't be communicated with, they can't get to appointments, and it's a whole cascade of downward effects. I don't know, Doug, do you want to comment just on the housing insecurity part?
Well, the communication part, we make sure that all of our members have phones. We give them out left and right. We have access points, and then we sign them up for the federal phones as well system. We need to be able to connect with our members, and we've kind of there have been some prescriptions against texting Medicaid members, and we've kind of decided to ask for forgiveness if we're discovered, and we're doing a lot of it ourselves, and we're using Arcadia as our basis, whether it's an ad hoc campaign or it's a decided. We need to make sure that kids are getting in for their immunizations. We have programs where we're using Arcadia every week to send out these messages and communicate.
Thank you. Other questions? Yep.
That's a good question. So the question was about our health risk assessment. How are we? Do we have barriers in getting that information? Are we doing it over the phone? How do we get it? So one of the things we did. So generally, we mail it out to our members when they are new with our plan, and also once a year. We get some of those collected back, but we will target, based on our analytics, we'll go through and target members to call and follow up if we have not received one of those. And so a lot of that is having one of our community health workers on the phone going through all the questions. There is definitely the barrier of kind of that assessment fatigue with our members. Sometimes they get asked a lot of questions. Sometimes we're really trying to currently reduce the duplication. So pulling in some of the prepare data, if we can, from our providers, so that we have some of those questions already input into the system, essentially. So we're not just burning our members out asking all of these questions. But that definitely is something that we hear as feedback as we continue to add to this assessment, it becomes an issue.
Great, thank you. Our time is running short. We probably have time for one or two more questions, if there are any. Well, if not, I would like to just thank Robin and Doug very much for their really brilliant work on this project. And I would just like to say that a lot of times in healthcare IT, we see solutions that are looking for a problem. And what we have here is a customer that had problems, and they collaborated with Arcadia to find solutions. And that is much more gratifying. So I would like to thank them for this excellent work and this excellent project. And we'll do it again next year. Thank you.